Hey, how you doing? Thanks so much for joining us on this episode of Facebook Live for UT Orthopedics. I'm Matt Mays, and I'm being joined here by my buddy, Dr. Vishal Shah. One of the sports orthopedic surgeons here. I've been practicing right at 13 years, all in this area, in the sort of Sugar Land, West Houston area, and focus mostly on shoulder and knee injuries and sports medicine in general. And Dr. Shah, go ahead and introduce yourself.
Yeah, I'm here with Dr. Mays here in Sugar Land as well. I was actually grew up in this area, born and raised in Houston, and then went to high school here in Sugar Land. I've known Dr. Mays for those full 13 years. We've been kind of working side by side. We both do very similar things. I treat knee and shoulder injuries in athletes. We're excited to talk about some of those injuries today that we see, specifically ACL injuries and meniscus injuries. Being that it's about to be football season, we're going to see a lot of these injuries in the next few months. Nowadays, we see them kind of all year round with all the different sports that go on, from football to then going into basketball and soccer and skiing. I mean, we see it all year round, literally. But there's definitely a spike certain times a year, which we're about to head into.
Right.
So I think a lot of you guys you might see these on the news and see athletes that you follow that have these injuries, and then people you go to school with or whatnot. So we thought it'd be a good time to kind of catch up and give you the latest and greatest and kind of how we approach these injuries and kind of go from there.
Yeah.
So let's start with that. Like, let's say, Matt, you have a football player who's in training camp and they hurt their knee, come in to see you, and they're worried that they might have injured their knee, or specifically even, hey, doc, I think I tore my ACL. So what do you do when you see them in the office? What do you talk to them about? What do you ask them?
Yeah. So first of all, getting a good idea of what happened on the field is super helpful. Did the athlete have an immediate injury? Did they have a twisting injury? Do they feel a pop? Often, if you have that classic ACL injury, it's a twisting injury, and the patient will often even report feeling a pop. Subsequent to the injury, it might be several days before they come into the clinic, or it might be immediate. If they have gone several days, they might notice that as they walk, they twist or turn, and their knee might feel like it's going to buckle or shift. And if you have an injury that had a twisting injury, plus feeling a pop, plus as they're walking around, they've noticed that it feels unstable and it shifts, that's a pretty big bunch of red flags for concern for ACL tear.
Yeah,
so let's say you see that patient. Now what do you do?
So yeah, if that's kind of what they've told me, or that's the kind of injury they had, the next thing you would do typically is kind of go back a few steps and say, hey, have you ever experienced any of these symptoms before? Have you ever had this kind of injury on your other knee? If you have the injury in your other knee, you're definitely more prone to having it in this knee as well. So you want that history. Maybe they had a partial tear before and then they finished it off this time. So, those are the questions I'd want to ask. And then the next thing I would do is basically have them lie down on an exam table so we can examine the knee. That's where I think we get the most, the next most helpful thing. The history is important, of course, that pop and swelling. And then we want to examine the knee, because ultimately the ACL, it's a ligament in the knee. And when you tear that ligament, your knee becomes unstable. Mm-hmm. And so testing for stability in the knee is going to be the way to hone in on whether they have that injury. So you're going to test their range of motion. You're going to see where they hurt. A lot of times when they first come in, as you know, a couple of days out, the exam's kind of hard because there's a lot of pain, a lot of swelling. They're not going to move freely and comfortably. So getting that patient to relax is kind of the first hurdle that you have to overcome. Right. There's some tricks, obviously, we use, kind of tell them to relax their leg, let their toes go floppy. And, the more relaxed they are, the better exam you can get. So a lot of it's just, talking to them and kind of almost distracting them from what you're about to do to their knee so that you can get a good exam. But then you can do tests. You see the guys on the sidelines doing these tests when you're watching a game on TV or whatnot. There's the Lockman test where you're testing for the ligament stability. There's something called the drawer test. But a variety of movements and tests that will indicate if the ACL is torn, if the other ligaments are torn, and then you can get an idea about other structures in the knee. So the physical exam would be the next thing to do. And then would you order x-rays for that patient?
Yeah, pretty much anyone who's had a significant injury is going to get x-rays of that body part. And then in particular, this patient with an ACL tear is also going to have what we call an effusion, which is an acute swelling of the knee. If there's acute swelling in the knee, that's pretty much an indication. They're going to need an x-ray. And then based on everything that Dr. Shah was saying, he's now felt the knee and he's concerned that it's loose. At least with the ACL. There's several ligaments in the knee, and there's several other structures like the cartilage and meniscus that can be injured too. And so at that stage, we're having a conversation about getting an MRI to get it further worked up. At that stage, just to make it real life, the patient, from a clinical standpoint, we're getting an MRI, and then we can go into that in a second. But you're also dealing with this patient, which could be a 14-year-old athlete that's got big aspirations for his high school football career, or it may be a professional athlete, a professional soccer player, and she might be thinking about, what is this going to mean for her future? And so there is always a little bit of a balance of how to handle the information flow, because me in particular, I know I don't want to dump a whole lot of things on them right at once. Even if you're pretty sure they tore the ACL, you might kind of hedge and just focus on, hey, let's get your range of motion back. Let's decrease the swelling. Mm-hmm. We can give them appropriate medication if they need anything for pain, crutches if they need that, start working on these things. And then I'll usually say, hey, let's get the MRI. Let's, not make any big decisions right now. I will mention that sometimes a patient right out of the gate will say, hey, if I've torn my ACL, what does that mean? Mm-hmm. And the first thing I'll tell them is, whatever you've done to your knee, I promise we can get you back to the sport you love. So I think that's important to kind of set expectations for the worst case scenario. You're still going to get back, no matter what it is. And so, sure. So let's say you get that MRI and then, they come back and see you, and what's next?
Yeah. So, I agree. Even that first visit, before you get the MRI, sometimes they come with the MRI.
Right.
You try to soften the blow. That's the first thing you do, because this is devastating news for the patient, the athlete, the family, whoever's with them, coaches. This is about the worst thing an athlete can hear, is that you might have an ACL tear, and that most of the time that pretty much means that particular season is over. So, right. So going along with what you said, you kind of also read the room sometimes. There's some patients who just want to know, what's the deal? Right. What's the worst case scenario? Doc, tell me like it is, right?
Right.
And then other times you definitely kind of say, well, there's a chance you have this. We're going to get the MRI to make sure. So, but once you kind of know what's done or what's torn with the MRI, then you start getting in the more details about treatments, like what options do we have? There's different ways to do surgery for these injuries. And then you start talking about the timelines for recovery, because ultimately that's what they want to know. When can I be back on the field? So the more information you get from them, the better. I always ask them, what other sports do you play? Because yes, this may mean your football season's done, but if you play baseball in the spring and we get this fixed, you get your rehab going, and things go the way they're supposed to, then there's a good chance you can make part of that baseball season or all that baseball season. So I had that exact conversation today with a kid who was pretty bummed out about, potentially tearing his ACL. But as soon as you give them that news, you want to give them the good news, right? Like you said, we're going to be able to get this fixed. There's light at the end of the tunnel. We'll do our part to fix the injury. You'll do your part to rehab the injury, and then together, we'll get you back to this or what comes next. So
along those lines, I often will bring up professional athletes that all of these patients have heard of, and you can right off the bat name 15 people that have had a ACL tear and come back from it, back in the NFL, MLB, they're playing soccer, so it's definitely helps, I think.
It's also a sign of, I use that exact example to kind of put myself in check, to realize that I'm getting older and older, because it used to be a different athlete, and now I know these kids haven't heard of that athlete anymore. So I've stopped using Adrian Peterson so much, and now I'm trying to find out, okay, who's the latest and latest and greatest, but that's an aside. But so I think I kind of hinted at most of these injuries probably require surgery, but how do you decide if they need surgery? How do you have that conversation with the patient, the family, and what other options are there?
Yeah, that's a great question. Your ACL is a main stabilizing ligament in your knee. And so if you don't have a functional ACL, then your leg can shift. Your knee can kind of buckle and shift. And there's a few different things I want to get into with a patient. One is some people are more ACL dependent than others. In other words, some people without an ACL have a hard time, walking down the hall and turning right because their knee will buckle. And then others can perform pretty normal to a pretty high level without an ACL, and you might be surprised to find that they didn't have an ACL. But the only time they notice it is when they're playing basketball and they make a certain move and they feel a little twinge. And so I think there's a spectrum of how ACL dependent a certain patient is.
Yeah.
Then really the big thing is kind of age, activity, interest, things like that. I don't draw a hard line on age, for example, and I'd love to ask you this, but I would say most everyone who's young and active that tears their ACL pretty much is going to get surgery to have that fixed.
Yeah, I agree.
As you get older, then the activities change a little bit. Where for example, if you have a 70-year-old that has a trip and fall and tears their ACL, they may or may not need it. But what about the 70-year-old who does 10 or 12 days snow skiing, and they tear their ACL, and maybe that person tears it? Do you still say, what do you say to that person?
I mean, I agree 100%. It's not necessarily about age. It's about activity and what the patient does. And that's usually what determines treatment, what guides treatment. So that 70-year-old who skis, several weeks a year, most likely is going to benefit from having the surgery. Or if not, at least having that conversation that, we can try to rehab you, brace you, see how you do, because like you said, they may be very ACL dependent, they may not be.
Right.
And you can always do the surgery a little bit later if they find that it's just not working out. They're having that instability.
Sure. Yeah, I agree with that. And Vishal mentioned a good one about bracing. So, certainly for maybe the medium to lower demand patient, you might be able to brace them, and that might be enough for them. Probably or pretty much not going to be enough for a high school, athlete. But kind of for the more middle-aged recreational athlete, a brace might be a good alternative. Do you use bracing much? Patients will ask you, hey, what if I just brace this? Can I just keep playing football?
Yeah, I think that's a tough question, and it's a lot of times patients want to do that just to get through their season and then fix it in the off season or fix it when the time is better. I usually kind of try to steer them away from that. And I also want to educate the parents, because it depends who's making the decision. If the kid's 16 and has to do what his parents say, I definitely want the parents to really make the final decision, because at that point they're really going to be looking out for his or her future interest.
Right.
But ultimately, doing high-level sports and activities without a functioning ACL, as you said, your knee's kind of bouncing around in there. The brace can only do so much. So it's not that patients can't do it or maybe not be able to be successful on the field, but they'll do additional damage to their knee. They'll tear their meniscus, they'll tear other injuries, they'll damage their cartilage. And those things, even though we can eventually fix the ACL, sometimes if you damage the meniscus or cartilage enough, then even after you fix the ACL, there's permanent damage that won't be able to be undone. So a 14-year-old who's thinking about right now won't really be able to process that with the full implications of what it might happen 10, 20, 15 years from now.
Right. I think that's a great point we hadn't really talked about. We've been focused on kind of getting back to play or things like that. But in a certain sense, reconstructing the ACL is a way to create a safer environment for the knee where it is less likely to go on towards arthritis. A isolated ACL tear with no meniscus injury, no cartilage injury, long term, those tend to do great. Whereas what dictates whether or not they have a bad arthritic knee 10 years, 15 years down the road is likely those other injuries, the meniscus tears. You mentioned cartilage injuries. You only get one layer of cartilage on the end of your bone, and if you damage that to a certain extent, it's gone, and that's what we obviously refer to as arthritis. So,
so that, kind of going back to why we fix the ACL, I think I tell patients there's kind of three reasons why we fix it. One reason is to get you back to doing what you're doing right now, right? Back to sports, back to those activities that require a higher level of stability. The next reason is to kind of prevent those subsequent injuries that would happen if you don't have a stable knee, like the meniscus tears, the cartilage tears. And then the third reason is really to prevent the long-term problems, the arthritis. So if you have damage to your ACL, you have damage to your meniscus and then cartilage, you're going to end up deteriorating that knee and developing a lot of arthritis in that knee, which doing a surgery to stabilize the knee now hopefully prevents that long-term.
Yeah, I think that's great. So maybe let's talk a little bit about, now this patient knows they have an ACL tear and you've got an MRI and now it's time to talk surgery. What do you do? How do you fix an ACL?
So there's different techniques. I think you and I do things a lot the same way, and then there's things that you and I will do differently. And if you ask 10 orthopedic surgeons how they do this surgery, there's differences between the way everybody does it, and there's not really a right or a wrong. There's kind of different nuances that if I'm good at doing it one way and Dr. Mays is great at doing it another way, the important thing is how the patient does long term. So the goal is to replace the ACL in general. When this ligament tears, if you can think of it being like intact like this, when it tears, it kind of stretches and then it almost just kind of explodes in a way. It's not like a neat tear that you can just sew back together. Those fibers get real stretched out and they don't do well if you just sew them back together. So we have to actually replace the ligament. So in a knee, so this is an example of a knee, we'll move kind of the kneecap in the front, we'll move that out of the way to look inside. And the ACL ligament is this one right here. It connects the tibia bone to the femur bone. So when this structure tears, we have to replace it with something. And the way generally it's done, we take that patient to surgery. They're under anesthesia, be asleep, they won't feel anything during the procedure. And we use a camera to look inside this knee. The camera is put in through two little holes on either side. You might have seen patients who have those little scope portals, we call them, on the side of the knee. We can go in there, look inside, remove the old ACL, and then we actually drill a hole in the bone from here out to where this ACL attaches. And then we do the same thing for the other side in here. And then we pass a graft through that bone into the knee and into this bone. And then when we fix it on both sides, then you've got a new ACL in the middle. So that's kind of the gist of how the surgery is done. There's different techniques of how to fix the graft to the bones, different things you can use for the graft. Do you want to touch on kind of what you use or what types of things you might use and how you decide what kind of graft to use for different patients?
Yeah, I think, kind of high level conversation is we'll talk about different graft choices. A patient could have the most gold standard down the middle is going to be bone patella tendon bone, which is a piece of your patellar tendon, the sort of the central third. Or there's the hamstrings graft, which is 2 out of your 6 hamstrings. And those are both kind of primary ACL reconstructions that have been around for many, many years. They both do really well. They've got great history behind them. And candidly, you don't really miss what it is you took out of the patient. Some more modern techniques, we're starting to use the central third of the quadricep, which is another very good, strong graft and has more and more research behind it. But basically, I think between the graft, and then, sorry, I should have mentioned, then there's your own tissue and there's cadaver tissue. So certainly we'll do some ACL reconstructions where we use the tissue from a cadaver where we're not having to take anything from you. As kind of a very broad strokes stereotype, I would say the younger, more active, I'm using more of the patient's own tissue, autograft. The older and maybe perhaps less active, I'm using some allograft, which is tissue from a cadaver. But that's a really nuanced conversation that I have on an individual basis with every patient, based on what their activities are, what they like to do, what their expectations are, and things like that. So let's say you've done the surgery, and just broad strokes, what does the recovery look like?
So the first couple of weeks are probably the slowest as far as what a patient's able to do and what work they're allowed to do. But in general, do the surgery, it's outpatient, they'll go home the same day typically. And then we start physical therapy. So the physical therapist kind of has a recipe for what to do at what stage, right?
Mm-hmm.
So we'll go over this with the patient, of course, and we'll tell them, for the first couple of weeks, we're going to be focusing on range of motion for their knee, getting the swelling down, getting your pain under control from surgery, things like that. So generally, the first 2 to 6 weeks are really about that, getting basic range of motion, getting you off the crutches, getting your knee moving again. And then month by month, we'll start adding things. We'll start doing some light body weight strengthening exercises. Then we'll start doing eventually a jogging program. Then we'll get back to strengthening the knee and with more weights and things. And then the last stage is kind of that return to sport, getting ready to return to sports. We're doing agility exercises and then more sport specific stuff. Yeah. And then of course there are things that you have to accomplish to then move on to the next level of recovery. In general, I tell my patients it's going to take anywhere from 6 to 12 months. And that variability, I think, depends on how motivated the patient is sometimes, how bad their injury was. Is it just an ACL or do they have other injuries? And it also depends on kind of what their goals are. If they're not in any particular hurry and just trying to get back to kind of their level of activity, it might be okay to take their time and get to it when they can, versus a professional athlete who's basically jobs on the line to get back as soon as he can, he or she can, then they're going to be getting a lot more rehab and putting a lot more time into it. And so they might get closer to that 6-month range versus the 12-month range. What do you tell them as far as, because the first thing I'm going to say is, and every time they come back to see is, Doc, can I go back to sports? When am I going to be ready? So how do you kind of gauge that decision, and what do you tell them as far as what you're looking for to get them basically released?
Yeah, it's a good question. I'll back up real quick and say about another thing we talked about, softening the blow. So when I hit that 6 to 12 month conversation, that can seem quite overwhelming.
Sure.
So certain patient populations, it might be, like my wife tore ACL a couple of years ago. She was, mid-30s, loves to play tennis, etc. And the first thing she's thinking of is, how am I going to manage 3 kids and carpool with a 6 months off my knee?
Right.
And so I think it's important to kind of discuss with the patient, hey, it might be 6 months for you to start returning to sports, but it's actually only going to be, 3 to 6 weeks where you're limping around on crutches. Big difference is, hey, don't worry, you can run carpool. You can start walking. A lot of our patients like to exercise. Hey, we're going to get you back to exercise as quickly as possible. Maybe we start out on a stationary bike, which you could literally do in most cases on day 1 to day 5 and get going. And then by 6 weeks, you're really feeling good. And by 3 months, hopefully, we're getting you back to start jogging. So although the return to play is a common thing we talk about, I think return to their life is an important thing, particularly for kind of the older, not high school athletes. But generally, you're walking without crutches anywhere from 1 to 4 weeks. Might depend a little bit on the other things you had to do in there. You can generally be walking for exercise around 6 weeks. You can be jogging by 3 to 4 months. So I think that's kind of an important conversation. To get back to your original question about what do I tell them I'm looking for when they can return to play. We now have a set of tests that we can measure, where we can say if you can pass tests A, B, C, D, E, and F, then we feel good that you can go back to the sports without high risk of re-injury. The reason that we have to explain to the patients on why you can't go back earlier is mostly a lot to do with their quad strength. If their quad strength is not back, the muscle in the front of their leg is weak, then they're still going to be at risk for re-injury. Whereas if you get good strength, then you're going to be able to protect yourself, protect your ACL, and kind of get back at that.
Absolutely. Yeah, I think that's exactly right. The strength component and their ability to pass certain physical tests is going to be like the final benchmark to say, okay, you're able to protect yourself from re-injuring that ACL. And the other things, of course, the whole timeline thing is really based on the biology of actually healing, because we talked about kind of how we attach the graft, we attach it to both of these bones, but once you leave the operating room and it's attached, it can re-tear very easily until it's actually healed. I use the example for patients of like planting a tree. So you can dig a hole and put the tree in the ground, and pack a bunch of dirt around it, but you can come back tomorrow and pull that tree right out of the ground, right?
Right.
So what's going to make that strong and when it's actually healed is when the roots have kind of grown into the ground and taken hold, and then you'd be hard pressed to get that tree out of the ground.
Right.
So the ACL is the same way. You reattach it to the bones, but until it actually heals into the bone, it's not going to be strong. It's not going to be like alive.
Right.
So that process takes anywhere from 6 to 12 months alone, depending on different healing factors. So So you've got the strength factor that we talked about. You've got the biology factor, and then the last one, which you see all the time. Some patients just aren't ready until
the mental
time.
component.
The mental component.
Right.
So those are kind of the three things that we talk about or talk to patients about. Some patients are mentally ready from 2 months into surgery,
Right.
and other patients are going on a year, and
Right.
they're just, I'm not so sure. So every patient's different.
Right. I think that mental component is something that's important, and as physicians, we can help them with that. But that's also something that is nice about having a stepwise progression through therapy. It's nice to have the test where they can pass this test and say, hey, I passed this, so I'm good to go. I think that helps give them confidence. But realistically, I think it does take sometimes even a year or two before patients are just 100% confident in their knee. So
for sure.
Anyway, yeah. So what about patients often ask about risk of re-injury to the ACL? What do you say about that?
It's a common question. It's devastating to think that you could go through the surgery, the rehab, go through all that time investment, and then still re-injure the knee. So, I would tell them it's always possible. If you meet all the goals that we talked about, the risk of re-injury is actually fairly low. There's no exact rate of percentage of chance that you'll re-injure it. In different studies, it can range from 3% to 15 to 20%. There's different factors that kind of go into it, but I tell them that the chance is generally low if we go through all the right steps.
Right.
And if you are patient with the recovery. We used to tell patients a lot they're actually more likely to tear their other ACL than the one that was reconstructed because of some factors that might predispose you to have an ACL tear. But it's a difficult question because I don't like quoting a number necessarily. I just tell them the chance is low if we do, and that kind of gives them responsibility for their knee as well, right? Mm-hmm. It's not just that the doctor fixes it and then everything should be fine.
Right.
It's, like I said, we do our part and then you do your part, and then together we should have a good success rate.
Yeah, I think that's great. Well put. So let's change gears a little bit. Meniscus tears. We talked about ACL tears, which is generally a trauma, generally some sort of twisting injury. So ACL tears are very, very broad. I don't know how much time we have on Facebook Live here, but so we might, keep that part short. But Let's just talk real quick about, why don't you tell me the most classic patient, or maybe some of our audience might have had this happen or have a friend that had, what's going to put your ears up thinking this person might have a meniscal tear?
Meniscus tear. So the meniscus is like a shock absorber between the two bones of the knee, the femur and the tibia. And the classic thing I would say would be somebody comes in and says, I'm feeling this catching or painful clicking in my knee, and when I first get up from a chair, I kind of have to get up and kind of almost baby the knee or protect it for a few steps, and then as I get going, I can move it a little better. Mm-hmm. That and them kind of pointing right to that inside part of the knee, that's usually kind of shoots off the warning signs they might have a meniscus tear.
Right.
What do you think?
Same. So I refer to it as what's called mechanical symptoms, which is just basically, when a person twists or turns, they might feel a catch, a pop, a click, something, but they'll describe something that when they twist or turn while weight bearing, they feel a little something in that. And it's like you said, usually on the inside or the outside of the knee. It's generally activity limiting. People can still do pretty well sometimes running in a straight line or walking in a straight line, but it's that twisting or turning that bothers them. Mm-hmm. And I would say that meniscal tears are a huge spectrum. You've got the 14-year-old that tears their meniscus as a result of an injury on the soccer field, and then you've got the 75-year-old that tears their meniscus getting up from a chair.
Yep.
And so they have a broad range of treatment based on who that person is. But real quick, let's, people to hear about, so-and-so tore their meniscus and they're back on the football field in 3 weeks. And then so-and-so was playing basketball and they had meniscus surgery and they're out for 4 months. What's the difference?
Right. So the difference is really the size of the tear and mainly the location of the tear, and if that was treated by removing a piece of meniscus or repairing the meniscus.
Right.
Like, it's a very slow tissue to heal and it's very delicate. So if you do a repair of that meniscus, which means you actually put stitches in across the tear and kind of sew the torn pieces together, that's going to have to be protected, and it's going to take those several months to heal and recover, and it's almost more like an ACL recovery.
Right.
Versus the...
Waiting on that biology you described.
Exactly,
Yeah.
waiting on the biology for healing. Versus, the most common type of tear is a little flap or a little edge of the meniscus, which is kind of torn loose, and it's irritating and aggravating and causing those mechanical symptoms, but it's not a tissue that can be repaired, which means in surgery you just go in and trim out a little corner of that unstable fragment. And those surgeries and recoveries are a lot faster. That's what you'll see. Oh, I went in and out, had my scope, and a couple weeks I'm back playing tennis again. So I think that's the big difference that we see is what was actually done. So,
right.
So when you have a patient who has a meniscus tear and they say, "Doc, do I have to have surgery?" They might say, "Yeah, I don't want to have surgery because so-and-so was out for 4 months. I don't have time for that."
Right.
What do you tell them about treatment options? Do all meniscus tears need surgery?
Yeah.
How do you gauge that?
Yeah, good question. I think, the big overarching thing on whether or not a patient's going to do well after meniscal surgery is truly how much arthritis they have in their knee. So let's say if you have a patient that has quite a bit of arthritis in their knee and they have a meniscus tear, then we have a big conversation about the main reason they have pain usually is the arthritis, and that meniscal tearing is degenerative. It's as a result of the arthritis, and we really don't advocate for surgery in those patients because they just frankly don't do very well with a small knee scope. It's not going to take care of the bigger problem, which is the arthritis.
Exactly.
The more fun, because they do so well, surgery, is the healthy looking knee that has an unstable meniscus tear. So every time this person twists or turns, they feel a little catch, and they haven't been able to do their activities. Those are great, and because those are going to do great with surgery, you can identify that on the MRI. You know what you're getting into. That surgery takes about a half an hour. You're in and out the same day, and I tell them, hey, you can be walking immediately. The crutches may be used for 1 day, but I often tell patients that the ones who do the best are the ones who don't have time for this, and they go right back to their activities. I usually tell them you'll be walking without a limp within a week. You can go back to most any activity within 2 to 3 weeks, and high-level activity within 4 if you do your rehab. So those are very satisfying if that's all it is.
Yeah, I agree. I think the mindset that you're talking about for those patients, like you're setting the mindset that, hey, I'm going to do this, but it's to get me better quickly, and you don't want them kind of overprotecting it if they don't need to. Those patients usually do very well. So I agree 100%.
Yeah, good. If all of our patients had simple meniscus tears and did great, that would be perfect.
That would be perfect, yes. And if they all bounced back from their ACLs in 6 months and did amazing, then we'd both be amazing doctors.
So anything else you want to talk about? I think we're good, huh? All right. Thanks so much for joining us, and thank you, Vishal. It's been, I have to say, being in practice with this guy for 13 years has been a true joy from colleagues and friends, and getting to learn from each other. It's been great. So,
definitely.
Appreciate it.
I'd let him operate on me anytime.
He has operated on me before.
That's right.
He did fix my shoulder, and it works great. So, all right.
Thank you.
Thanks.